Welcome to Knowledge on the Go, the podcast brought to you by the PI programs team at Vizient. Patient safety indicators, or PSI, are not just quality metrics. They reflect whether patients are being harmed on our watch. It's about accountability. It's about performance. Most importantly, it's about protecting our patients. Joining us today is Katelyn Dietz, Director of Patient Safety and Quality at Lake Charles Memorial, to share her experience and how her systems navigates PSI. I'm Michelle Lewis, Senior Director, PI Programs at Vizient, and your host. Katelyn, so glad to have you with us today.
Thank you, Michelle. I really appreciate you asking me to join and giving us a chance to share our story. I'm happy to share what's worked for us and what we've learned along the way.
Great. How did you all decide to put a focus originally on PSI?
We have continued to struggle with our PSI rates for a couple of years, and then we went to a new EMR in October of 2024, and that PSI rate just continued to go up. When I really did a deeper dive into the numbers, compared our data in Vizient to other hospitals, I found that the other hospitals had the same amount of events, but their expected rate was much higher than ours. So leaning towards more of a documentation challenge and wondering what we could do about that, but without the resources to know. I knew we needed a bigger team and an expert in that area to guide us through that improvement project.
So you established a standardized criteria for selecting cases for review. What is that criteria, and how did you decide on that criteria that you would use?
AHRQ made it really easy to decide. Through the Vizient PSI Collaborative, we participated in several educational sessions where organizations shared what was working, what wasn't, and helped us get in touch with those best practices that consistently showed strong results in implementing that stop bill process for HACs and PSI's HACs being hospital-acquired conditions within the EMR, allowing cases to be reviewed before they ever proceeded to billing. We partnered closely with our EMR team to build the process using the AHRQ definitions for HACs and PSIs. And anytime one of those conditions is coded as not present on admission, it triggers a quality work queue for me and my team to review. The standardization in that process gave us a consistent way to decide which cases needed attention.
From what I understand, every PSI points to a moment where something may have gone off track. Maybe it's a missed signal, a communication breakdown, or documentation that didn't fully capture a patient's story. How did bringing those multiple departments together change that approach to solving this issue?
Every PSI represents a moment where something may have kind of gone off track. And bringing those multiple departments together did shift the conversation from it being an isolated event to shared ownership, which always helps get improvement projects done faster when multiple people take ownership in their portion of it. When quality coding, CDI, case management, our clinical leaders, and our frontline staff all reviewed these cases together, we stopped looking at it through a PSI lens of this is a safety issue or this is a coding issue. We looked at the process breakdown where it really was going wrong, and then from the multidisciplinary perspective, it helped us identify patterns that we would have missed otherwise working in our silos. It strengthened that trust between teams, breaking down those walls where somebody's not defensive and they're answering you honestly. The clinical teams gained a better understanding of how documentation and coding decisions impact PSI outcomes. And our non-clinical partners gained insight into asking if we made a mistake, where did the process break down, and what can we do to make it better? The transparency changed the tone of the work. It became more collaborative and less focused on being defensive and solution focused.
We're really hearing from organizations that one of the biggest challenges with PSI performance is separating that true clinical quality concerns from documentation. What approaches have you found work best when engaging physicians in documentation improvement?
It came down to respect, relevance to them, and the timing of the discussion. We are working towards more quality metrics with our providers, and that brought up really good conversations with them. Physicians were far more engaged when they understood why the documentation mattered, when we connected the dots between documentation, PSI outcomes, and how those reflect patient harm. The conversation changed. It became more accurately telling that patient's story and protecting the care that they delivered. It becomes about our near real-time queries and working on clear, concise messaging with our query teams, more of a team approach, being collaborative with our coders and our physicians. Using the concrete examples has really helped. Telling them a story like, okay, this patient had a DVT present on admission. However, it was not documented at the H&P. 3 days later, a pulmonologist documented after their procedure that they have a DVT, and now it's a post-op DVT, when in reality it was present on admission. So those simple things, having those discussions has really helped that partnership. I've tried to involve the physician leaders early. I share trends. I talk about it in every provider meeting that I'm in, and just closing the loop with them to show them how improved documentation has positively impacted that performance. It helped to have the data to back me up. When physicians see that those efforts lead to fewer false PSI flags and clearer outcomes, their engagement was much more sustainable for us.
I love that using stories gives a face to the issue at hand. We've recently heard from organizations struggling with that post-operative sepsis rate, so PSI 13, which you saw improvement in. Any big insights that you would share with your peers looking to improve in this area?
PSI 13 is extremely challenging because it involves so many different care areas. The biggest insight was realizing the improvement in this measure starts well before the patient ever becomes septic and likely before surgery. We focused heavily on that baseline risk, who's coming in at risk, so our urology patients having lithotripsy, and making sure the documentation on admission was present and working with the providers. What else could we document that would indicate this patient was likely already on the road to sepsis? These patients are usually already high risk. They weren't clearly captured preoperatively. Sometimes it's an emergent procedure, so getting a good history from that patient is hard. We focused on making sure we're getting accurate histories in the ED if we can, because our normal process is for the floor nurse to do that part, making sure we're honing in on those documentation things early, ensuring those comorbidities, infection risk, any present on admission indicators were clearly documented, help us reduce the false PSI flag so we could better stratify patients who needed that closer monitoring. This one is truly a multidisciplinary measure. We needed to meet with the physicians, the nurses, our sepsis coordinator. We pulled her in. What are we missing? Is there any opportunity to detect this earlier? With each case, we do a deep dive on each one to see if we have opportunities. And if we find it, we give feedback, closing that loop.
You also saw substantial improvement in the patient safety composite score, PSI 90. Any advice that you would give your peers or anything surprising you worked on specific to PSI 90?
None of these are easy measures. This one is overwhelming when you look at how many things go into it. It reflects multiple indicators, multiple workflows, and many teams. My biggest piece of advice is don't treat this one like one metric to fix. Instead, break it down into each component and understand what's driving each of those measures for your organization. What worked for us was establishing that strong team first to really look at those cases, running those case identifications through our peer review if we had a real case, and then working through those false cases with documentation challenges. So was there an exclusion that we failed to document? Was there a present on admission condition that we failed to catch? Once those foundational pieces were in place, we could focus on our efforts for the clinical care portion. I'd also encourage teams to look at balancing that documentation accuracy with clinical improvement. It was how much improving just one measure really changed the overall score. As we strengthened that admission documentation and communication, we really saw improvement across all of those measures, not just a single one.
I'm hearing a theme, a lot of collaboration across different teams in the organization and taking the time diving in to understand where your opportunities were. How do you sustain these improvements that you're seeing? What does the future of your standardization and your process look like?
The work queue is helpful to making sure that work is part of our normal operations. It's in our work queue that we check every day to see if there are PSI or hacks, and it ensures that we're following our process. And if we don't do it, the finance staff is reaching out saying, why aren't these bills released? From the beginning, we were very intentional with building this process. The stop bill workflow, standardized case review, and then the multidisciplinary involvement has not been temporary. We continue to reach out to our partners. They educate me most of the time when I say, hey, why couldn't we code this way? Or they ask me questions if they feel uncomfortable with something. And they're embedded now into our daily work. We also heavily focused on those feedback loops, regularly reviewing our PSI trends, sharing those learnings among our medical staff, continuing to talk about it and being transparent. As our new providers come on board, I also do an education with them. We also have LSU residents. I spend a lot of time educating them on what their documentation means on the back end, where their information goes, and the importance of making sure we're accurately documenting those cases on admission. Our future focus is really on refining and automating where possible, using that data earlier instead of being reactive, making us able to be proactive on the front end. If there's one takeaway, our PSI improvement wasn't about chasing the metric. It was about building a more reliable system to protect our patients. And you can't do that when the data is full of noise from documentation challenges. When organizations focus on that standardization, bringing the whole team to the table and not siloing, the data becomes a tool for learning rather than frustration. The sustainable improvement happens when our patient safety is really embedded into our daily workflows, which is our ultimate goal.
I love using data for a tool for learning, just takes that negative out of it. Thank you, Katelyn, for chatting with us today, sharing your experience, the great work that is being done at Lake Charles Memorial. And thanks to you for listening. For Vizient's PI programs team, I'm Michelle Lewis. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.